All right, let's get started. Welcome everyone to a Bite Medicine webinar on chest pain. For those of you who don't know me, my name is Shoaib, and it's an absolute pleasure to have you all joining, on a Thursday evening when I'm sure you can be doing many other things, or maybe not in lockdown. But nevertheless, I'm grateful that you're all here. So what will this webinar be on? It's kind of what it says on the tin. It's going to be on chest pain and how we approach chest pain. The way I've structured this is I want to give you guys some useful tools, not only for your exams, but also practically, because chest pain is a super common presentation, particularly in A&E, GP, even on the wards. Patients just tend to develop chest pain. So you need to know how to tackle it and how to figure out bad chest pain from good chest pain, i.e. urgent from non-urgent cases. We're going to go through some common presentations, a few bits and pieces on management, but really I want to focus on how you're going to derive your differential diagnosis. Hopefully it won't be longer than 45 minutes, but I do have a habit of overrunning. Regardless, the slides and recordings are on app.bitemedicine.com, and the slides are available right now to download. If at any point you have any questions, just post them in the Q&A function and I will get to you, or just message in the chat. Okay, so as part of the Bite Medicine website, not only do we run webinars, but we have a massive question bank, case-based questions, which I think are the best way to learn rather than single questions on random topics. We take you through a case right from first steps through to diagnosis, through to management and pathology. A bunch of these are free as well if you don't want to pay. And along with the text, with the question bank, we have our online textbook. And again, that goes through conditions in depth. If you want to get a discount on the Bite Medicine textbook and question bank, you can use my discount code Shoaib2021. I'll type that in the chat, and that'll give you 20 to 30% off subscription. So please do check that out. Some people are asking, where is Azim? Is he not part of Bite Medicine anymore? No, he's still around. I think he's doing some webinars at the end of the month, so please do tune into those as well. Check out my discount code, check out our product, and let's crack on. So what is chest pain? What's the definition? Well, I mean, it doesn't take a genius to work out what chest pain is. It's pain in the chest, right? Thoracic pain, you could call it. But what I really wanted to impress is that chest pain is super common. So 5% of visits to A&E will be chest pain. And as doctors and physician associates, you're all going to be doing an A&E rotation, or pretty much all of you will be doing an A&E rotation at some point. So 1 in 20 patients you see, if not more, will have some form of chest pain. And 1 to 2% of primary care consultations, so GP consults. Interestingly, I'm not sure how much I believe this stat, but this is what NICE says. 50% of patients presenting to A&E with chest pain have a cardiovascular cause. So the 50%, half of the patients who do turn up with chest pain to the emergency department have a cardiovascular cause. What are the causes of chest pain? So we can split them up into cardiovascular, respiratory, gastrointestinal, and other. And the reason we're dedicating a webinar on this is, number one, this is going to come up in your exams and your OSCEs. And number two, chest pain can be dangerous. Certain presentations of chest pain are lethal, and it's important we know how to recognize them. So what I want you guys to do is list all of the urgent causes of chest pain, all of the serious causes of chest pain in the chat. So we've got PE, very good. MI, Good. So we've got PMI. Yep. So ACS, I like that. Acute coronary syndrome, pneumothorax, dissection, tamponade. Okay. Good, good, good. Oh, perforated ulcer. I like that a lot. Very good. So you're an A&E, you're going to present your case to your consultant, and he or she is going to turn to you and ask, what is your differential diagnosis? And this is when you need to know how to formulate a differential and how to come to a diagnosis. Here we go. This is a table of chest pain differentials, so cardiovascular, respiratory, gastro, and other. The cardiorespiratory causes are the ones that we really need to hone in on and focus on, because these are the ones that are serious. Gastrointestinal causes are rarely urgent or serious, other than in the case of an esophageal rupture or a perforated peptic ulcer, but those are rare. I've never seen either. And the other causes like musculoskeletal and psychogenic, of course, whilst you need to treat them, they're not going to kill the patient. So let's go through these in turn. I've tried to give it some structure here. So cardiovascular vessels, we're thinking ACS, acute coronary syndrome. So that's NSTEMI, STEMI, and unstable angina. Any pathology affecting those coronary arteries, atherosclerosis of those coronary arteries, it's going to lead to acute coronary syndrome, okay? Aortic dissection, we'll come on to that later, but again, that is a potentially lethal diagnosis and something that you need to consider. Pericardial disease, so pericarditis, this is rarely a problem and often self-resolving, or it can be solved with ibuprofen. So if someone does present with pericarditis, you don't need to be too worried. Myocarditis can be dangerous, okay? And this is inflammation of the myocardium, and we'll again come on to this later. Valvular disease like aortic stenosis can cause some serious problems, and conduction-related issues, again, can cause serious problems. So just have this structure in your head. Moving on to respiratory, again, thinking of vessels, pulmonary embolism can be potentially lethal. Pleural disease like pneumothorax, well, a tension pneumothorax can cause hemodynamic instability and eventually death. Pleurisy is inflammation of the pleura. That is not serious. Airways and alveoli problem. So we're thinking pneumonia, asthma exacerbation, COPD exacerbation, and rarely lung cancer can also present with chest pain. So as I said, the cardiorespiratory causes are the ones we really need to focus on and rule out those serious conditions that I just mentioned. Other causes to consider are gastrointestinal causes, so the esophageal problems. And remember, the esophagus runs behind the heart. So therefore, esophageal problems can present with chest pain. A really common presentation to the emergency department is reflux, gastroesophageal reflux disease. And really annoyingly, it can present very similarly to ACS, acute coronary syndrome. Sometimes it's quite hard to tell apart reflux from a myocardial infarction based on a history alone, and you need to do further tests. Esophageal spasm and esophageal rupture. So esophageal rupture is an emergency. Peptic ulcer disease can also present with chest pain. And again, this may be an emergency if there's significant GI bleeding or a perforated stomach or duodenum. Other causes, so musculoskeletal, costochondritis, that's inflammation of the costochondral junction. Tietze syndrome, that's an inflammatory disease of the costochondral junction. And it's typically a disease, a diagnosis of exclusion. Someone said rib fracture, so that would also fall under musculoskeletal, but rib fractures in general aren't an urgent diagnosis. And then you have things like panic attacks. So that's kind of chest differentials in a nutshell. This isn't an extensive list. You know, there's probably you could probably think of another 50 diagnoses which would cause chest pain. But these are the high yield ones that you need to focus in on. A lot of you are raising very good points and other diagnoses that can cause chest pain, like, you know, cholecystitis and cholangitis. They can cause chest pain, yes. Someone said, can esophageal varices not cause chest pain? So varices in and of themselves don't typically cause chest pain, no. So remember, it's the cardiorespiratory ones that we need to focus in on. Some general principles when you're taking a history. So this patient has come to A&E, they're complaining of chest pain. You need to really explore the pain in depth with Socrates. I know this might be basic for some of you, but just to go over some of the facts, we start with sight. Where is the pain? If it's left-sided, we're thinking, could this be a myocardial infarction? If it's come on suddenly, that's more worrying than if it's come on gradually. What's the character like? Is it crushing? Is it pleuritic? Is it tearing? Is it burning? So crushing suggests usually a myocardial cause, like an MI. Pleuritic is typically associated with things which cause inflammation of the pleura. So that includes pneumonia, pulmonary embolism, pleurisy. Tearing is typically associated with aortic dissection, and burning is classically associated with esophageal problems. Does the pain go anywhere? Does it go into the left arm? Does it go into the jaw? That's suggestive of acute coronary syndrome. Does it go between the shoulder blades? That's suggestive of aortic dissection. What are the associated symptoms? Difficulty breathing, nausea, sweating, collapse. How long has the problem gone on for? You know, if something's in general has gone on for months and months, it's not going to be particularly acute compared to something which is, you know, come on suddenly and happened over the course of hours. What makes it worse? So exertional chest pain, again, suggests a myocardial problem, such as acute coronary syndrome or stable angina. Lying flat. What diagnosis is lying flat associated with? Good. So pericarditis classically is made worse by lying flat and better by sitting forward. And again, what severity? Is it from 0 to 10? How many painkillers have they used? That will all give you an idea as to how bad this chest pain is. Some general principles about examination. So of course, you're going to start off with your observations. And the key thing to look for in the observations is any evidence of hemodynamic instability. So this concept is going to come up a lot in this lecture. But what do we mean by hemodynamic instability? Well, that means tachycardia and hypotension. The combination of tachycardia and hypotension is bad news because that means your heart is not pumping, the cardiac output is not sufficient. The heart's not pumping efficiently. And so your organs are not being perfused well. So hemodynamic instability is a bad sign. Of course, we know the different differentials of chest pain, so we're going to examine according to those causes. Examine the cardiovascular system, examine the respiratory system, examine the abdomen. Okay, nice, thorough examination. So, investigations, anyone coming in with chest pain, it doesn't matter what you think the cause might be, even if you think it's, gastroesophageal reflux disease, do an ECG. You never know, you might be caught out, you might get the diagnosis wrong based on the history. You do an ECG and it looks like they're having a myocardial infarction. Okay, always do an ECG. That is the take-home point. You guys will be in A&E at some point assessing these patients with chest pain, and they must have an ECG done. All other investigations will depend on what you think the diagnosis is. But right off the bat, you should do an ECG in a patient with chest pain. And I put together this table to try and think about what are the urgent findings, or what would suggest a serious diagnosis in a patient with chest pain. So the timing, if it comes on quickly, that is more suggestive of a serious problem. So things like aortic dissection and even ischemic heart disease, so acute coronary syndrome, these pains tend to come on fairly quickly. Crushing pain, remember that's suggestive of acute coronary syndrome. Tearing pain is suggestive of aortic dissection. Exertional pain, again, suggests coronary artery disease, i.e. acute coronary syndrome. And typically, serious chest pain doesn't just last for a few seconds, it tends to persist. So it lasts a good few minutes. It's very common for patients to come to A&E and say, I had some really bad left-sided chest pain, but it only lasted about 3 seconds. I've seen this on a lot of occasions. You know, pain lasting a few seconds is not going to be anything serious, really. If it's persisting, lasting, you know, a good 10 to 15 minutes at least, then that should make you worry. And if it radiates to like the left arm, to the jaw, to between the shoulder blades, those are worrying features. Now, if we think about associated features, if you have chest pain plus shortness of breath, that should always make you worry. If you have chest pain plus collapse, that should always make you worry, okay? Chest pain with collapse means that there is a problem with your heart not pumping blood effectively to the brain, causing collapse, okay? So it suggests a problem with cardiac output. If you have chest pain with hemoptysis, that can be suggestive of something like a pulmonary embolism, and also hematemesis. Okay, if you have chest pain plus hematemesis, that suggests a perforated ulcer or, you know, some form of upper GI bleed. Or even a non-perforated ulcer will also present with hematemesis. Chest pain in an elderly patient should always worry you, okay? Whereas chest pain in younger patients tend to be less serious cause. As we said, examination, look out for hemodynamic instability, look out for evidence of acute heart failure, look out for radio-radial delay, and look out for a new murmur. So what does radio-radial delay suggest? Good, aortic dissection. And what does a new murmur suggest? It can suggest lots of things, but in the context of chest pain, endocarditis, yes. Endocarditis doesn't necessarily cause chest pain though. So chest pain plus a new murmur, what does that suggest? Aortic dissection, good, and myocardial infarction. Aortic dissection and myocardial infarction can both cause a new murmur. The reason myocardial infarction can cause a new murmur is because you can damage your papillary muscles. And if you damage your papillary muscles, that will cause valvular incompetence. It will cause essentially the valves to break in layman terms. Good, let's move on to the case. So we have a 60-year-old presenting to A&E with severe central chest pain radiating to the back. He feels lightheaded and nauseous, and he has a background of hypertension. He's got radio-radial delay, and his observations are listed there. What is your diagnosis? Okay, quite straightforward, yes, aortic dissection. And therefore, you should all be very worried. If you've got this presentation turning up to you in A&E, you've got someone complaining of chest pain radiating to the back, look at their observations. Their heart rate is 107. Their blood pressure is 99/66. You know, their blood pressure is low. Their heart rate is fast. You know, that is a worrying sign, as I said. So this should make you concerned. Let's move on to the question. So if we turn our attention to Menti. Please don't answer in the chat. So what is your first line management in this patient? 500 mils of fluid, major hemorrhage protocol, urgent surgical repair, labetalol or monitor. Bearing in mind they have an aortic dissection. So to answer this question, go to menti.com, it's listed at the top of the slide, and put in the code 95840724. And that's menti.com. You should be able to answer the question online. I'll have a look at some of your questions. Is perforation the same as a bleed? So perforation of an ulcer or perforation of the esophagus can cause an upper GI bleed, but even a non-perforated ulcer can also cause an upper GI bleed. So I hope that answers that. Should you always check a femoral pulse in these patients? You should, yeah, it's good practice too, but it's not really going to change your diagnosis. If they got radial delay and they've got chest pain going through to the back, your top differential will be aortic dissection, regardless of whether you check the femoral pulse or not. Okay, so the majority of you went for urgent surgical repair. Why is that the correct answer here? So, yeah, okay. But is that your first line management? So if someone comes in with an aortic dissection, is the first thing you're going to do take them to surgery? If they're hemodynamically unstable, they're tachycardic, they're hypotensive, the first thing you should do is give fluids. Eventually, they might need surgery, they might not, depending on the type of aortic dissection. But the first thing you need to do is stabilize the patient, okay? Remember, management is A, B, C, D, E. You secure the airway, you sort out their breathing, and then you sort out circulation. Circulation involves giving fluids. Remember, this patient is tachycardic and hypotensive, which suggests they're bleeding, okay? They're losing blood volume, which is making their heart pump faster. And because they're losing blood volume, they're becoming hypotensive. So what is the first thing you're going to do is you're going to give fluids, and then after that, you're going to sort blood out, okay? You might activate the major hemorrhage protocol, you might not. You might just cross-match blood and give them appropriate blood, but that depends on the clinical context. The point is, the quickest thing you can do in this instance is put in a cannula and give fluids. It's going to take time to get blood, regardless of how you do it. The quickest thing you can do is give fluids. Someone's asked, would you not do fluids and activate major hemorrhage at the same time? You might do, but the point is the first thing that's going to go into the patient will be the fluids. Secondly, you don't necessarily have to activate major hemorrhage protocol just because the patient has an aortic dissection. You might still have time to cross-match blood, figure out what their group is, and get them the appropriate type of blood. It depends on what their hemoglobin is. It depends on how what their blood pressure does over time. That's why surgical repair is not the first thing you do. You need to stabilize the patient first. Always remember A, B, C, D, E. Someone asked a really good question earlier, and what are the atypical presentations of aortic dissection? And actually, that's a really good question, because that's what I want to touch on in this lecture, is that whilst in the textbooks, it's typically chest pain going through to the back with a radial delay and a radiofemoral delay. That's not how things always present. Well, actually, in the case of aortic dissection, most cases do present with that classic tearing chest pain, but it might not necessarily be radiating through to the back. It might not necessarily be tearing. Most cases that I've come across, it has been a fairly classical presentation. But that's not the case when we come on to things like myocardial infarction, which can present very atypically. So what is an aortic dissection? It's a tear in the tunica intima with blood dissecting through the tunica media. It's rare and it's associated with high blood pressure, smoking, bicuspid aortic valve, coarctation of the aorta, and connective tissue diseases like Marfan's and Ehlers-Danlos syndrome. So, structure of the blood vessel. We have got the tunica intima, which is the inner layer, the tunica media, which is the muscular middle layer, and then the tunica externa, known as the adventitia, which is the outer connective layer, connective tissue layer. In an aortic dissection, you get basically a tear through the intima, and then blood leaks into the tunica media and dissects through it. So you get a tear in the tunica intima here, blood can then enter and essentially rip through the tunica media, and that is a big problem. So in the UK, we typically use the Stanford classification when it comes to aortic dissection. We have type A aortic dissection and type B aortic dissection. So if we turn back to anatomy, we've got our left subclavian artery. If the dissection happens distal to the left subclavian, that's known as a type B. And if it happens proximal, that's known as a type A. And that's really important to note because the way you manage a type A and the way you manage a type B are different. I can see quite a few questions coming through, so let me just address a few of them. Some of you have asked about permissive hypotension, and I'll come on to that at the end. Just remind me. Would you not hold off fluids until the blood pressure is less than 90? Nope, because the patient is essentially bleeding into their blood vessel wall. They're going to keep dropping their blood pressure. You don't want to wait. You want to act before that happens. Okay. Next question. CT confirms a dissection confined to the descending aorta. What is your management? Looking at some of your questions, why is bicuspid aortic valve a risk? So it's just an association. It's known that patients with bicuspid aortic valves have a higher risk of dissection. How would you differentiate type A and type B on imaging? We can come on to that. How is the patient bleeding? Because they're bleeding into their blood vessel wall. So they're losing blood volume into their blood vessel wall. Okay, it's not leaking out of the blood vessel technically, but it's leaking into the wall and coming out of the lumen of the blood vessel. Okay, so the majority of you went for urgent surgical repair again. Why is that the answer or not the answer? What type of aortic dissection is this? If it's confined to the descending aorta, it's a type B. Type B aortic dissections are managed conservatively. You just give them anti-hypertensives, okay? And you control the blood pressure. So going back to our slide, type B dissections happen distal to the left subclavian artery, i.e. after the left subclavian artery has been given off. And type A aortic dissections happen before the left subclavian artery has been given off. Type B aortic dissections are managed conservatively. Type A are managed surgically. The reason for that is because if you have a dissection going backwards, what's going to happen? So if you have a dissection going this way towards the heart, what can happen? If you're having blood dissecting through the aortic arch back towards the heart, you can get cardiac tamponade, okay? Because that blood is going to leak through the blood vessel and then go into the pericardial space and squash the heart, causing cardiac tamponade and death. So that's why this is an urgent problem. Type B is also an urgent problem, but you don't need to take them for surgery. You can just manage them medically. So let's look through the investigations and management. First thing you need to do, it's chest pain. First thing you're going to do is an ECG. Okay, you want to check that this isn't a myocardial infarction. The next thing you want to do is you want to check the hemoglobin to see how much blood they're losing. You want to check the U's to see if there's any kidney failure. The reason you can get kidney failure is because as you get the blood dissecting along the blood vessel, it can block off arteries. It can block off side branches of the aorta, including the renal arteries. And if you occlude the renal arteries, you will go into renal failure because the kidneys won't be receiving any blood. The chest X-ray typically shows a widened mediastinum. So this is the mediastinum here, number 1. And number 2, this circle here, or this little hump here, is the aortic arch. So if these structures are widened, that suggests an aortic dissection. And essentially, to confirm the diagnosis, you need to do a Cta Autogram. And that's to check for a dissection flap. And someone asked, how can you tell if it's type A or a type B on imaging? Well, you can see exactly where the dissection has occurred on CT imaging, and you can see if it's happened proximal or distal to the left subclavian. Type A is an urgent surgical repair for the reasons I mentioned, and type B, you use IV labetalol, aiming for a blood pressure of around 100 to 120 millimeters mercury. The reason you want to keep the blood pressure low in these patients is because if we go back to our diagram here, if you have high blood pressure, that's going to continue to rip the tunica intima and dissect blood through the media. So if you lower the blood pressure, that's going to lower the forces occurring across the blood vessel wall and reduce the amount of blood that's dissecting. And eventually this will shut off and you won't keep bleeding into this space. So CT aortogram, also known as a CT angiogram of the aorta, same thing, okay? It's where you have contrast in the aorta. Heart, a bit of the diaphragm, black stuff is lungs. This is the aorta here, and this is a dissection flap. So normally this should all just be one bright white circle, but you have this gray flap, which is the dissected tunica intima, which has come away from the blood vessel wall. And that gives you this classic image. Good. So let's look through cardiovascular differentials of chest pain. Acute coronary syndrome, that consists of STEMI, NSTEMI, unstable angina. Our classical presentation is pain centrally or left-sided, which is worse on exertion, radiates towards the left shoulder or jaw, and is associated with shortness of breath, nausea, and sweating. So diaphoresis is sweating. That's the classic presentation. The atypical or non-classic presentation is sometimes patients don't even present with pain at all. They just come in short of breath, or they might sometimes have conspicuous right-sided chest pain. Essentially, things don't always present like they do in the textbook. You need to take everything into account. You need to take into account their risk factors, how old they are they smokers, do they have a past medical history of things like hypercholesterolemia, piece together the puzzle. You know, you need to do the appropriate investigations like an ECG and a troponin, and then figure out, is this ACS or not? But the classical presentation is the one I described, and I did an in-depth webinar last week on acute coronary syndrome. So do check that out. That's freely available on the website. Examination-wise, the patient may not have anything to find. If it's quite a bad MI, then they may have hemodynamic instability because their heart is not functioning properly, so they get tachycardic and hypotensive. Again, if it's a bad MI, then they might have acute heart failure, which will cause a raised JVP. It might cause pleural effusion. It might cause crackles in the lung because of pulmonary edema. They may have peripheral edema. So these are all things to look out for. And as I said earlier, if you damage the heart valves in your myocardial infarction, that can lead to a problem with the heart valves, leading to a murmur. And you're doing serial ECGs and troponins, okay? You usually measure the troponins. If you do it twice and you measure it 3 hours apart to look at the trend. Aortic dissection, type A, type B, as we discussed, that classic sudden onset central tearing chest pain radiating to between the shoulder blades. They may be hemodynamically unstable, radial or radiofemoral delay, and again, difference in blood pressure between the arms. It depends what source you read, but greater than 10 to 20 millimeters mercury. So there'll be a difference in blood pressure between the arms. We went through the investigations, but essentially the diagnostic investigation is Cta Autogram. And pericarditis can either be idiopathic or viral are the most common causes. And then you have some other rarer causes like rheumatological problems like lupus, for example, or rheumatoid arthritis can also cause pericarditis. Again, it's pleuritic pain, it's sudden onset central pleuritic pain, and it's usually worse when patients lie flat, and it's improved when patients sit forward. And this is a classical presentation. Patients do often present like this. You know, you'll see them leaning forward, grabbing their chest, because leaning forward makes the pain better for them. It's associated with shortness of breath and infective type of symptoms like fever, you know, cough, runny nose. Those are the associated features. They may be tachycardic. Usually you won't really find anything on examination. These patients are quite well. This isn't necessarily a serious condition that you need to be too worried about. And they may have a pericardial rub. You'll never hear this. You'll only read it in textbooks. So I wouldn't worry too much about it. You just need to know it for exams. Just know the words pericardial rub, because sometimes they might mention it in your exam. The ECG, the classic finding is widespread ST elevation and PR depression. So PR depression is the most specific finding on the ECG for pericarditis. Pericarditis, the name suggests, is inflammation of the pericardium. Therefore, if you have an inflammatory process going on, your inflammatory markers like CRP will be raised. And you want to do a chest X-ray and echocardiogram just to rule out any other potential serious causes of chest pain that you might be missing, like a pneumothorax, for example. So you can do a chest X-ray for that. Myocarditis is inflammation of the myocardium, and it can be infectious or non-infectious. It can present similarly to acute coronary syndrome, but they may have additional features of infection like fever, and it will typically present in your younger demographic of patients, whereas ACS will present in older patients. These patients can be very unwell with hemodynamic instability and evidence of heart failure. And essentially the way you need to work this up is by doing a troponin, and the troponin in myocarditis will be raised. And that's because you're damaging the heart muscle cells, and they are gonna get damaged and release troponin into the blood, much like in a myocardial infarction. The inflammatory markers will be raised, The ECG may show ST elevation. The echo will help you figure out if this is myocarditis or not. So you need to take into account the whole clinical context. Aortic stenosis, the most common cause is senile calcification. So calcification of the aortic valve, and this will be seen in the elderly. Less common cause is bicuspid aortic valve. So the aortic valve normally consists of 3 cusps. In a congenital disorder, the aortic valve can consist of 2 cusps, and that's known as a bicuspid aortic valve. And these patients are prone to aortic stenosis. The point is, if you have a young patient who develops aortic stenosis, the cause will be bicuspid aortic valve. If you have an old patient who develops aortic stenosis, the cause is calcification. These patients present with exertional chest pain, shortness of breath, and syncope. You can use the acronym SAD, syncope, angina, dyspnea, to help you remember that. The point is they present with chest pain and a murmur. So you hear an ejection systolic murmur radiating to the carotids, diminished S2, a narrow pulse pressure and a slow rising pulse, and they may have evidence of heart failure if it's severe. The ECG will show evidence of left ventricular hypertrophy because the left ventricle is contracting against a narrow valve, so it's having to work extra hard to push the blood out. You can do an echocardiogram to look at the valve itself and how wide the gap is between the valve cusps and the jet speed, i.e. the velocity of blood moving across the valve. So does anyone know what orifice is suggestive of severe aortic stenosis? This is something that you should know for finals. Tricky question. Yeah, good. So less than 1 centimeter squared is suggestive of severe aortic stenosis. Know that figure, 1 centimeter squared. Okay. And finally, arrhythmias can cause chest pain as well, because in arrhythmias, your heart is not pumping efficiently. If it's not pumping efficiently, you're going to have poor perfusion of the coronary arteries, which will lead to chest pain. And typically, these patients also present with shortness of breath and syncope. It can be tachyarrhythmias or bradyarrhythmias. You'll have a feel of the pulse to see if it's irregular. These patients may be hemodynamically unstable with evidence of heart failure. Essentially, the first thing you need to do is, of course, check the ECG. And then you can do other investigations to see what the underlying cause of the arrhythmia might be. So in the case of atrial fibrillation, for example, electrolyte imbalances, like hypokalemia, for example, can cause atrial fibrillation. Okay, have a read of that case and I'll try and answer some of your questions. Why do you give antihypertensives if the patient is hypotensive? So yeah, obviously if the patient is very hypotensive, you won't do that. You will give antihypertensives and titrate the patient's blood pressure between 100 and 120-ish millimeters mercury. If it drops below 100 or starts to get quite low, then you will stop the medication. What would you see on echocardiogram in pericarditis? You may see a pericardial effusion. Okay, good. Let's have a look at this. A 60-year-old lady with COVID has been isolating at home. She's now developed a deterioration in her breathing and now has chest pain, worse on inspiration. She has a background of anterior resection for rectal cancer 2 years ago, and those are her observations. So what's the diagnosis? Pulmonary embolism. Good. The patient is tachycardic. Their blood pressure, I mean, it's a little bit low, but it's not too worrying. The respiratory rate is 25 and they're hypoxic. Okay, so this is concerning. This patient you are seeing in A&E and you're racking your brains, what do I need to do next? So what is your first line investigation? In this patient, okay, in this specific patient, what are you going to do? You think this might be a CTPA? Sorry, this might be a P. I think it gave away the answer. You think this might be a P? Yeah, I mean, I think I said it accidentally, but the point is, it's not D-dimer, it's CTPA. Why CTPA, not D-dimer? Good. Well score. Someone's asked, would you not do a well score first? Absolutely, you would do a well score first. That's the first thing you're going to do. And what's the patient's well score? To be honest, I have no idea what the patient's well score is, but the point is it's high, okay? The patient's well score is high. It's above 4. I don't know what it is exactly because no one ever bothers to learn the precise criteria of the scoring. The point is this patient is a high risk PE patient. So you jump straight to CTPA. Yeah, don't worry about learning the well score inside out. You know, I think people are probably, there are more exciting things to do in life than learning the well score. But we know this patient is high risk. That's basically it. So it's a CTPA. Sorry, that's wrong. It's not D-dimer. The answer is CTPA. What is a pulmonary embolism? Well, it's an embolus to the lungs. It's an embolus usually arising from a DVT, which obstructs the pulmonary arterial system. It's the 3rd most common cardiovascular disease after MI and stroke, and approximately 50,000 cases of P in 2013 and 14. Very common. Pathophysiology, Virchow's triad, if we go back to our sort of first, second year of med school, consists of hypercoagulability, venous stasis, and endothelial damage. Any one of these dysfunction, any one of these criteria can increase your risk of forming a thrombus, which will then embolize to the lungs, causing a PE. I'm not going to go through all of these. We've done an in-depth webinar on pulmonary embolism and DVTs a couple of months ago, so do check that out if you're interested. Again, I think that one's freely available. Well score. Again, like I said, don't worry about knowing this inside out. Basically, this is a way of figuring out how risky a patient is. Is a patient high risk or low risk? What I would note is that if the patient has a DVT, that gives you 3 points. And if the patient, you know, if you highly suspect they have a PE from their history and examination, that gives you another 3 points. Other things are tachycardia, immobilization, recent surgery, past medical history of clots, malignancy, and hemoptysis. So if we actually calculate our patient's well score, I would say PE is the #1 diagnosis here. So that's 3 points. They are tachycardic, so that's 1.5 points. Do they score for malignancy? Yes or no? They had an anterior resection 2 years ago, rectal cancer. So they do not score for cancer because they don't have active cancer. It's not been within the last 6 months. Score of greater than 4 means PE is likely. Score of less than or equal to 4 is unlikely. Let me throw in another score for you. You know, I'll throw in 2 for the price of 1. The PERC score. This is actually really, really useful, and it's super useful in A&E. It stands for the PE rule out criteria score. If all of these criteria are fulfilled, the PERC score is 0. If the PERC score is 0, there's less than 2% chance of a PE. If there is less than 2% chance of a PE, you do not need to do a D-dimer, you do not need to do a CTPA, you just send the patient home, and that is the end of the story. So if the patient is a low risk for PE, and no is the answer to all of these other questions, So their age is less than 50, they're not tachycardic, they're not hypoxic, they don't have a DVT, they don't have hemoptysis, they have not had recent surgery or trauma, they have not had a past medical history of clots, they aren't on hormones like oral contraceptives, then their PERC score is 0. You send the patient straight home. You don't need to bother doing anything further. It's a really cool score, something which is used a lot in A&E. Someone's asked about the Pesi score. The Pesi score, you use that once you've diagnosed a PE to see how, essentially how risky that PE is. CT confirms a PE. What is your management? Let's have a look. It's a very good question. Someone's asked, what's the cause of radial delay and radiofemoral delay? It's because of the dissection. You're going to have differing perfusion to your different limbs. Okay. Can I go back to the vignette? We will go back after this, sorry. Are there any other causes of radial delay? Someone has asked. Good question. Have a think and let me know if you can think of any. There are other causes. So most of you have gone for rivaroxaban, which is interesting. And the answer is, drum roll, rivaroxaban, very good. This is the new nice guidelines, okay? Before the guidelines were a bit different. Now we say first line for a PE is rivaroxaban or a DOAC. And yes, all of you have said very appropriate answers for causes of radial delay, coarctation of the aorta. In the chat, I've got atherosclerosis. Exactly, all very good. Rivaroxaban is first line for a PE. Some of you might have thought alteplase, but that's only if it's a massive PE. So a massive PE is a clinical diagnosis, and it's if the patient is hemodynamically unstable. Okay. Or if there is a genuinely massive clot on the CT, like a saddle embolus. Otherwise, rivaroxaban is your go-to medication. And this is the recent NICE guidelines, which have been updated in March 2020, if I recall correctly. All right, how are we going to work up a patient with PE? ECG, chest pain, always ECG. Don't forget ECG. That's got quite a rhyme to it. Don't forget ECG. So sinus tachycardia, right bundle branch block, S1Q3, T3 you see in a minority of patients. ABG to check if the patient is hypoxic or how hypoxic the patient is. Chest x-ray is usually normal, but you want to make sure they don't have something else which is causing the chest pain, like a massive pneumothorax. Echocardiogram to look for right ventricular strain. So imagine if your right ventricle is pushing against a massive embolus in your pulmonary trunk. That's going to be really tough work for the right ventricle to contract. And that's going to lead to what's known as right ventricular strain and right ventricular failure. And you can see that on echocardiogram. You either do a CTPA or a D-dimer depending on the Wells score. So if the patient's high risk, i.e. high Wells score, do a CTPA. If they're low risk, do a D-dimer. Management of a massive PE, i.e. someone who's hemodynamically unstable, is thrombolysis, which is exactly the same as fibrinolysis, and that's typically with alteplase, and that's a clot busting drug. Okay, that's a drug which activates your plasmin, your fibrinolytic pathways, and actually actively breaks up the clot. If it's a non-massive PE, NICE suggests anticoagulation with DOAC as a first line, and these are medications which inhibit the clotting cascade. So thrombolysis activates the fibrinolytic pathway, Anticoagulation inhibits the coagulation cascade. That's the big PE there, that dark gray stuff, that's a thrombus, and that's a saddle embolus because it looks like a saddle and it stretches across both the left and right pulmonary arteries. And that is very concerning. So this is the algorithm. If you suspect a PE, do a well score. If your well score is high, do a CTPA. If your well score is low, do a D dimer. If the D dimer is raised, then you do a CTPA. If the D dimer is not raised, you can think about excluding PE as a diagnosis. Okay, so that's the investigation pathway and the management pathway for pulmonary embolism. Okay, we'll be another about 10 minutes or so, and then we'll wrap up. So respiratory causes of chest pain. PE we've gone into, so I'm not going to touch on that, but the key thing is do a well score. That's the take-home message. Pneumothorax, be tension, primary or secondary. Pain is typically sudden onset and pleuritic, and you have associated shortness of breath. In a secondary pneumothorax, they typically have underlying lung disease like COPD. These patients can present with hemodynamic instability and shifted trachea if there is a tension pneumothorax. A tension pneumothorax is one where the mediastinum gets shifted to one side and the heart starts to get compressed. Typical examination findings are hyperresonant percussion and reduced breath sounds on the side of the pneumothorax. Of course, you want to do an ABG to check oxygenation, but ultimately chest X-ray is the thing that's going to be diagnostic. Pleurisy is very commonly seen. It's inflammation of the pleura. It can be infectious or non-infectious. Typically is caused by a viral infection. Patients present with pleuritic chest pain. It can present very similarly to a PE. Okay, but patients may also have underlying infective symptoms like fevers, runny nose, cough. They're typically stable patients with nothing to find on examination. The key way to differentiate pleurisy and a pulmonary embolism is by doing a D dimer, okay? Because usually the D dimer in pleurisy will be normal. And of course, you do a chest X-ray just to make sure that this isn't a pneumothorax, because a pneumothorax can also present with pleuritic chest pain. So pleurisy is not a serious problem. You just discharge these patients home with simple paracetamol. But the key thing is make sure you're not missing a pneumothorax or a pulmonary embolus. Pneumonia, again, can present with pleuritic chest pain and shortness of breath, but typically they also have a productive cough with a fever. If the patient is septic, they'll be hemodynamically unstable, they'll be pyrexial, hypoxic. Over the area of consolidation, you will hear coarse crepitations and dullness to percussion. And patients will also have they'll have vocal resonance over the area of consolidation. Curve 65 is the score that you calculate, and that tells you how severe the pneumonia is. Check the CRP, check the white blood cells, check an ABG if they're hypoxic, do a chest X-ray to see where the chest infection is, and do a sputum culture so you can figure out what nasty bugs are growing in the patient's lungs. COPD exacerbation, again, can present with pleuritic chest pain. This is a lot more easier to diagnose because patients will have a background of COPD. Okay, they'll be increasingly short of breath, increasingly wheezy. They'll be using their inhaler lots and, can present with the standard things like hemodynamic instability, wheeze, coarse crepitations, vocal resonance, all of those infective symptoms. And again, it's a very similar workup to pneumonia. And finally, asthma exacerbation presents in a similar way, and you work it up in a similar fashion. The only difference is in asthma exacerbations, you do a peak flow. In COPD exacerbations, you do not do a peak flow. And again, these patients will have a known history of asthma, making it a lot easier to diagnose. And that is respiratory in a nutshell. So have a read of that case. There's some good questions coming in. In ED, do we start rivaroxaban or low molecular weight heparin? So there's being a shift towards starting rivaroxaban in ED. Clinically, can we differentiate unstable angina and NSTEMI? No, you can't. Have a look at my ACS lecture, and that goes into things in a lot more detail. Okay, 38-year-old male comes in with severe central chest pain, which wakes him up at night. He's vomited. He's been given GTN, which takes 15 minutes to work. He smokes occasionally, he likes to binge drink, and he's taking ibuprofen for a knee problem. What's the diagnosis? So we've got angina, we've got GORD, got a lot of GORDs. MI until proven otherwise, ulcer, reflux, gastritis. There's some controversy here. What's your first line investigation? Okay. So a lot of you are saying GORD. So if you think it's GORD, what are you going to do of these investigations to figure out the problem? Good. You all listened, or nearly all of you, took heed of that first few slides. Anyone with chest pain, the first thing you do is an ECG. It doesn't matter if you think it's GORD, if you think it's an MI, if you think it's an aortic dissection. Chest pain, do an ECG. So I'm glad you guys got that. But don't worry if you didn't get that. Now you know. You're not going to make that mistake again. So ECG, what is the diagnosis here actually? So this is, I put this case in on purpose because it's a mixed picture. If I had to give a diagnosis based on this, I would say this is an esophageal problem like reflux or esophageal spasm. I don't think this is a heart problem because number one, the patient is young, they're completely stable, they don't have any risk factors. He's an occasional smoker. Occasional smoking in and of itself is not really a risk factor. It's only prolonged smoking. He's got risk factors for an esophageal problem because he's taking ibuprofen. Okay, so he might have some gastritis or esophagitis. And importantly, what's this business about the GTN relieving pain after 15 minutes? Why is that significant? Because isn't that classical of angina? Because I can understand why some of you said angina. So in heart problems, GTN works in less than 5 minutes. In non-heart problems, like esophageal problems, GTN takes longer to work. So GTN should provide almost immediate relief if this is ischemic heart problem, like an MI or angina. In esophageal problems, it takes longer, okay, and that's really important. So that's a nice little clue in the history that this is an esophageal problem and not a heart problem. That's the distinction you want to make because most gastrointestinal causes of chest pain aren't serious. So reflux, how does it typically present? Retrosternal or epigastric burning pain, worse after meals or lying flat. Patients typically taste acid at the back of their mouth, they feel sick, they're vomiting, and they're bloated. So going back to the case, the patient woke up at night with the pain. And that's significant because reflux is worse when patients lie flat. Patients are typically stable. They might have some pain in the epigastrium. And the way you don't necessarily need to do any investigations if it's clinically obvious from the history. But if you're worried about more suspicious findings like cancer, then you may wish to do an endoscopy. Or if it's an unclear diagnosis, then you can do endoscopy and pH monitoring, where you can actually measure the pH of the esophagus over 24 hours. Esophageal spasm can mimic acute coronary syndrome, or it can be very similar to GORD, and that's where your esophagus contracts and causes very severe, intense pain. It's associated with reflux, and it can cause problems with swallowing. Obviously, if your esophagus contracts, your food's not going to be slipping through nicely, and that's going to cause swallowing problems. Again, stable patient, and the way you can assess for this is with endoscopy, pH monitoring because it's associated with reflux. Barium swallow, you can actually see the contractions of the esophagus on the barium swallow, and esophageal manometry. So that's measuring the pressures within the esophagus, which may be raised in certain conditions like achalasia. The key thing is GTN can cause pain relief in esophageal spasm because it's a muscle relaxant. So it's going to stop those spasms, but typically takes longer than 5 minutes. Whereas in MI or angina, it should provide much quicker relief. And the key point is GTN can also provide relief in GORD because GORD is often associated with esophageal spasms. So, if someone comes in with an esophageal problem, giving GTN might actually improve their symptoms. But GORD alone, not in association with an esophageal spasm, shouldn't really be relieved by GTN. Boerhaave syndrome, so that's rupture of the esophagus, spontaneous rupture of the esophagus, usually caused by retching and vomiting, or more particularly profuse vomiting. Okay, sorry, not retching, it's typically caused by profuse vomiting, and that leads to sudden onset chest pain. Patients can be very unwell, they can be septic, hemodynamically unstable, and the diagnosis essentially is made by a CT of the chest, which can show where the rupture is, and also it will show air in the subcutaneous tissues and in the mediastinum. Patients will have surgical emphysema because the air leaks out of the esophagus and into the subcutaneous tissues. And if any of you have ever felt surgical emphysema, it essentially feels like bubble wrap. So you'll feel the patient's skin, and the skin will feel like bubble wrap because all the air is leaking out of the esophagus and into the subcutaneous tissues. And finally, peptic ulcer disease. So this can present in a similar way with that retroesternal epigastric burning pain, improved by meals if it's a duodenal ulcer, or worse with meals if it's a gastric ulcer. Patients will be vomiting, they might have hematemesis. Patients can be well or they can be unwell depending on how significant the bleeding is from the ulcer or if there's any perforation. You should always check the rectum for melena in a patient with peptic ulcer disease or any upper GI bleed. So that is black stools, okay? Upper GI bleeding causes black stools. Investigations, if it's not acute, you check for H. pylori and you can do an endoscopy non-urgently. If it's acute, you want to check the hemoglobin, you want to check the patient's urea because urea is raised in an upper GI bleed. You want to check the patient's lactate on a VBG, a venous blood gas, which is also raised in a bleed. You want to check the chest x-ray to see if there's any perforation. You'll see air under the diaphragm, and you'll do urgent endoscopy to check for the site of bleeding and treat the site of bleeding. Again, we have an in-depth webinar on upper GI bleeding and peptic ulcer disease, so please do check that out. And finally, this is super common, musculoskeletal causes of chest pain. usually presents as pleuritic chest pain. It's sharp, it's localized. So what you must ask patients to do is to point at the area of pain, and they'll be able to localize the pain with a finger. They'll literally point to the area that it hurts. Whereas in an MI or PE, the pain is less localized. You don't really need to, you don't need to do anything specifically. You just want to exclude serious pathology. So you'll do a chest X-ray to make sure this isn't a pneumothorax, for example. And of course, always do an ECG. Let's wrap up on a top decile question. Is there still a role for morphine in MI? Absolutely. So you give GTN and give morphine. So the faster you answer, the more points you get. Which of the following is associated with myocarditis? Time is ticking. That's why it's a top decile question. Tricky one. What's this disease called? Trypanosoma cruzi. What does that cause? You will need to know this for your finals, because they like asking annoying questions like this. Yes, Chagas disease. So I don't really know how to pronounce this. Trypanosoma cruzi, I think it is, but that causes Chagas disease, which these are protozoa. Okay, the Trypanosoma species are protozoa, and one of them causes Chagas disease, which causes myocarditis and esophageal problems like achalasia. Okay, and this is seen in America. The top two are causes of African trypanosomiasis, which causes different disease known as sleeping sickness. Wucheria bancrofti causes lymphedema, and this one, Trypanosoma brucei, is not. It's not a complete organism. It's either Trypanosoma brucei gambiens or Trypanosoma brucei rhodesiens. Okay. So remember, check out our website. It's got plenty of questions, textbook topics, which go through things in really nice and concisely. You can use my discount code to get 20 to 30% off. And I put that in the chat. Here is a little summary flow chart, which you can look at in your own time. That's on the slides. It's just basically the really important acute urgent conditions which present as chest pain, how to manage them. And that's all in this flow chart here. Please fill out a feedback form and drop your questions in the Q&A and I will get to them. So I'll stick around for a few more minutes to answer your questions.